out where it's starting from. I mean, where some of those culprits or some of those suspects of that low back pain might be coming from. And so we have below the lumbar spine is our hips, our pelvis, and above our lumbar spine is up in our thoracic spine. So those are two typical big rocks, and there's something either lacking mobility or lacking strength in one of those two areas, or both, that are contributing to more work happening at the lower back. Either more motion happening from the lumbar spine or more muscle effort from those lower back muscles. So how do we figure it out? Well, there's two little assessments that we do that are pretty quick to kind of show us where we need to go first. And it's a hip assessment and it's a thoracic spine assessment. In our previous video, chatted a little bit more about flexion, extension, lateral motion, rotation, and then combinations of type 1 and type 2 spine. So feel free to reference that and just use it for your lower back pain assessment. Today we're going to talk more about the hips and how to figure out where we need to go first, either with some soft tissue techniques, maybe just some stretching techniques in the true stretch, or the mobility stick, or maybe it's just moving those areas that haven't gotten motion before. So we have to think about our front hip, we've got to think about our posterior hip, we've got to think about medial, we've got to think about lateral, and then also our rotational dynamics, and that's typically where we're most limited, or where most of that dysfunction lies. Now we got to think the lumbar spine, we have our psoas that attaches down into our femur, and up into T12 all the way through L5. So that can typically be a big culprit, especially if somebody's got a lifestyle of sitting, flexing, traveling, or anything that pulls their core forward or into more flexion. So we're going to look at psoas. We've also got to take a look at our adductors that also come up into the pelvic bowl and down into the legs. And we've got to think about the TFL. We've got to think about the glutes, especially those muscles that are helping in rotation. If they're not helping in rotation, typically the lower back or the knees are going to be asked a lot more of. So for front hip, if we just go into a stride stance, into what we call into a left stride, we're looking at really the right hip's ability to extend, right? If we're going into a typical lunge, you might see somebody drop the knee down, not a horrible movement, but it might not give us enough information about how the anterior hip is loading. How much extension does it have the ability to eccentrically load or decelerate? So if we take a left foot forward lunge, we're looking at the lengthening of this right front hip and also its ability to contract back home from that load. Same thing when you take your right foot forward, we're looking at the left anterior hip. And typically if there's some kind of dysfunction at the anterior hip, what you're going to find is either a foot bailout in rotation, you're going to find a knee flex down to the ground, or instead of both of those, the hip will stop and you'll see a ton of extension, aka more muscle effort at the lumbar spine. So that's usually a quick hitter, seeing if that back foot turns out, as opposed to keeping them in that extension and internal rotation. They'll typically bail to external rotation and a bit of flexion forward, as opposed to that internal rotation and extension. That's telling you probably need to go after the front thighs, either with some soft tissue work, maybe just some other cueing, or adding some stability with mob sticks, a wall, or a chair, just to allow them to go through that extension through the hip, right? We don't have to do a ton of soft tissue work if we just need to teach their body how to go through the extension. Sometimes the access isn't there. We can even take this up into a box, so not even going into this stride stance, but maybe something more into just this extension. And typically what you'll find, if there's limitation at this front hip or even in the posterior hip, is we'll compress forward and put a lot of pressure and compression into the front side of our spine, making our low back start to ache quite a bit, right? Because now to come out of this, we've got to use those low back muscles versus being strong and allowing this hip to get that posterior tilt. Now for the posterior chain, more than looking at the hamstrings, the loading through the upper hammy and the lower hamstring. Remember, it attaches at the knee and up in the hip. And what most individuals will do in a hamstring load, right, if you go through a posterior stretch, is they'll try to lock out this portion of the leg, lock out the knee. That's not a bad thing, but typically we're going to get so much motion from that lower portion of the hamstring that we have got nothing to give in the upper. So for example, if we step our left foot back, lock into that hamstring stretch, yes, a ton of load, but we may not get the full anterior tilt of the pelvis to load the upper section of the hamstrings. So if we just emphasize a slight knee bend as we take this posterior lunge, now we can see if the pelvis can access its anterior tilt to load the upper hamstrings. If you're finding that they can't quite tilt, they just kind of bail, their hips stop tilting, and it's all through the lower back, that's probably a sign that we need to work on their hip hinging, especially in the upper section. That goes for both sides too, right? We can go with the leg straight, leg a little bit bent, but each of those is going to give you some different insight into how they load their posterior chain. Something a bit simpler is to put them up on a chair or box with that toe up and then drop in and seeing if they have the ability to posterior and anteriorly tilt the pelvis or if they just use their back to get there. It's so subtle, so you need to be very aware, even placing hands on hips, seeing if you can guide them into that anterior tilt. They might just not know how that feels or how to create that motion because they're so focused on keeping their leg locked out. There's times where we want that leg straight, there's other times where we want it to stay a little bit bent so that we can load the upper portion of the hamstring. Then we've got our medial chain, and this is where we see so much dysfunction, especially for those desk sitters or travelers up on planes or in their car driving for hours at a time. They're flexing the pelvis, they're not using any stabilizer muscles on the inner thigh, and so when they go to stand up and walk, those muscles typically stay dormant. They may be used in a percentage, but maybe not the whole adductor tissue, that whole medial line. So what we can start with is a wide foot position and just slide to our left and to our right. And what we're looking at is not just the translation of the pelvis, the shifting of the pelvis to the right and left side in space, but actually the tilting or the rotation of the pelvis in reference to the femur and our spine. So when we lunge to our left lateral, we want to feel our right hip drop and the pelvis tilt to the right side, loading those deeper adductors. Many people keep their pelvis flat and slide, and it creates this big gunky sensation up in the hip, and their back starts to compress and hold and squeeze because we don't want to go much deeper. But if we can start to access this tilt, now we're giving more love to the inner thighs and hips rather than to our lumbar spine trying to create that lateral flexion, right? The difference of this, where my spine is fairly straight relatively in the pelvis versus the pelvis is flat and we bend at our lumbar spine. And that's going to create more compression that's not necessary because our hips have the access as long as we're training them to do that tilt. So maybe foam rolling inner thighs, upper groin, getting in there with an elbow, or going up into that true stretch. Leg is up, hands can hold on so you got 4 points of contact, and we start to tilt our pelvis and drop our shoulder, feeling that upper inner thigh. And sometimes it takes some time just to rest here so that tissue can start to separate like taffy. Now we're starting to feel like, oh my gosh, it's sharp, it's a bit of a tug, but avoiding the pinch on the outside. And if we come back and retest, typically we'll find that there's quite a bit more tilt. And now the spine doesn't have to do it, the hips can do it. Then we've got our lateral lines. We've got 3 left here. It's super important on these. We've got our uncommon frontal plane stance, as we like to call it, which is simply an opposite side lateral step, which is going to give us an adducted hip position relatively, right? So we're loading our abductors. And what we'll tend to find is if somebody's got lower back dysfunction, and this is the cause of their pain, they're not going to be able to slide or translate their pelvis to the side. They'll try to go, but they'll lose their balance. They'll step, and then as soon as their hips start to slide, they can't quite go any further. They hit a barrier, hit a wall, as opposed to getting a nice slide to one side. You might find one side limited, other side ease. And that might be why they have this asymmetric pain. It's only on one side of their back because they're only accessing one translation or one way to laterally tilt their pelvis. You can take that up into the thoracic spine as well, but again, if we want to keep it more so in the hips, we're looking at the right femur's ability to adduct or get into the adduct position passively, right? I'm not forcing my leg to adduct. It's planted, my left leg comes across, and now we're seeing that eccentric load of the abductors. So if you're not seeing that load, sometimes TFL, sometimes the vastus lateralis, sometimes it's more up into the oblique that's compressed down in the connective tissue, and we just need to start to prime that tissue before we go into a workout. Squats or anything that involves lateral motion in the hips. You can take them up into a platform as well, onto a chair, and just see if they can slide their hips while maintaining stability here. Great way to start to access more of that range. Then over time, just 2 feet on the ground, they can get into that position. Then we got to look at our hips' ability to externally and internally rotate. When we walk, our pelvis is actually twisting right and left. If we had a top-down view of this, you're going to see my pelvis twist and my torso rotate opposite. We don't walk in sync with our thoracic spine and hips. We walk out of sync, and it creates this nice spiral and diagonal load through our front core and our back side. And sometimes that torsion, that twisting, is too aggressive. We don't have more that we can access. This is as far as we can get. That means we're going to be straining some of the tissues through the thoracic and lumbar spine and down into the pelvis. And so what we've got to do is see, do we have access into external rotation, and do we have access into internal rotation on this passive leg here, this stance foot. We're taking that femur into external rotation at the pelvis, and then taking that leg into internal rotation. If your client doesn't have access, typically what you're going to find is a bailout either in the knee. That knee's going to start to cave in and create tension here, or the low back, or they're able to keep the leg straight and it's compressing the outer hip because they're not allowing the tension to load on the inner thigh. And vice versa, when they come across, they might not feel the outer hip loading or might not have access, so their foot pivots or they start to compress down. If you're not seeing a smooth transition in that rotation, it's a good sign that you found a place to go target. Go do your soft tissue techniques, go stretch it, go move it around a little bit, and then come back and reassess. Do they still have that compression? Do they still have that bailout in the knee? Or now they're able to cue more successful, more efficient loading through the hips? So that should give you a good baseline. It's 3D maps through Grace to assessment of the full lunge matrix of anterior, posterior, same side lateral, same side rotation, opposite side rotation. We're going to keep diving deeper into this and even some techniques on, okay, you found that the knee bailed or the foot turned or that they couldn't quite extend and their knee flexed. So what do we do about it? Go check out Gymnazo EDU's Instagram, and that's when we'll be breaking down some more of those techniques, even checking out our multidimensional movement coach certification to be able to apply these techniques to your clients. Good luck and enjoy.